Thank you, Minu, for the very kind introduction. And I'm really thankful to our colleagues over here. We had formed a 30-member core user group initially for the B-HEX. Minu, Dr.Arup, both the Arups, all of them were part of it, and we got some useful feedback, and there were a lot of design modifications. And the version that is in front of you today is courtesy their contributions. My contribution has been all in the past. Thank you so much for that. So we'll move on to IFIS. Now, the IFIS is basically a bundle of surprises. It's surprises at every stage. So you need to brace yourself for surprises as they come along. I have a financial interest by way of my patents that have been granted. So in the OPD, when you're seeing a patient, what, according to you, would be a safe pupil size where you can say, okay, this guy is cool and I won't have IFIS? All of us have something in our mind, and we say, okay, this is going to be a no trouble case in the theater. So, well, unfortunately, this paper was published in 2011 by Alexandra Katsusio, and it said that a pupil of 7 millimeter or smaller, the risk of IFIS existed, regardless of alpha blocker. So 7 millimeter is what we would consider safe, but it's not so safe. So, Katsi, Chang, and Campbell, they gave a meaningful interpretation to what we were seeing and we could not interpret. There was something happening, so they recognized the term IFIS, and we all then kind of started seeing what we were not seeing earlier. So we would like to divide small pupils into 3 different categories. One is the senile myosis, uveitis, glaucoma, the non-elastic pupil. And I'm glad we are all talking about non-elastic and elastic because that makes a difference to your management. The IFIS pupil, which is typically elastic, which will keep coming down and going up, and then the pseudoexfoliation, which is often associated with comorbidities. Now, this was this survey in 2008, ACRS. 2/3 of the ophthalmologists responded that if they had mild symptomatic cataract and needed to take tamsulosin, they would avoid tamsulosin or have the cataracts removed first. That was the scare IFIS had caused in 2008. So repeated advisories were sent to physicians. That's general physicians and those who prescribe tamsulosin. Since 2005, ACRS, AO did a lot of active campaigning. So there was a survey of primary care physicians in California and Bay Area in 2014, and let's look at the results. Only 35% of the physicians prescribing alpha-1 antagonists were aware that they cause cataract surgical problems. It's no better over here. Only half factored it into the treatment conditions, and less than 10% took any history of cataract. Now, most of us think that, oh, we are not touched by this problem. Indian eyes are different. IFIS is a problem of the Western world. Sadly, we are mistaken. Prevalence of tamsulosin intake and IFIS incidence is higher in India. I would urge all of you to look at this paper by Dr. Shilpa Goyal and co-authors. And of course, current use of tamsulosin and hypertension are important risk factors. That's something we miss out. There are a lot of physical conditions, systemic conditions which cause IFIS. So broadly, there are 3 categories: mild, moderate, and severe. In the mild, you have good dilatation to start with. In the moderate, you have moderate dilated pupil, and in the severe, you have poor dilatation to start with. And in the mild variety, you just see the fluttering of and billowing of the iris. In the moderate, the iris billowing with some constriction, and the third, you have the full-fledged triad that's billowing, more progressive myosis, and iris prolapse through all ports. This is a video which I presented in 2013, and I was fortunate that my work was publicized hugely by ACRS and sent across the world. So this was the classic IFIS. I had not even recognized it, only when David Chang and they kind of brought it out. Then I went back and dug into my videos and saw this is a IFIS, so typical. You see, the pupil comes down, you inject viscoelastic, and there goes, your pupil will again expand. This is so typical of IFIS pupil. And again, there's nothing wrong with my fluidics, and it was not that I was starting phaco or something. I was well into, I think about 7 or 8 years of phaco I had already put in. So this is, presently, if I were faced with a situation like this, I won't hesitate to use at least iris hooks or a pupil expander or something, anything that's available. So at this stage, we have iris prolapse through 2 ports. Fortunately, over here, it was not a very bad one, and we managed to get away with it. And every time I did inject viscoelastic, the pupil did enlarge, and so at the end of the surgery, I'm just kind of playing around with the pupil. Now, this is a severe IFIS. This is something where I saw IFIS signs right in the beginning. I used iris hooks, and despite that I'm having iris prolapse and I'm struggling. I have a frayed iris by the time I finish my capsulorhexis, and imagine what my plight is. And there I'm struggling to put my phacoprobe in. That's a good strategy. You take a side port instrument to disengage any iris that's coming into that phacoprobe of yours, and then you advance that phacoprobe. So use that side port very judiciously and strategically. Viscoelastic, top up time and again, and you can see that patulous iris over there. It's kind of a sail. You inject viscoelastic and it starts bowing out. And fortunately I had my iris hooks in place, so I could go ahead and finish this surgery. Otherwise it would have been a real nightmare of a surgery. And I had a knuckle of iris over there which I couldn't do much about. And again, when I'm injecting that IOL, I had to take care of that I didn't land up with an iridolysis, because that iris was already frayed and it's going to come over there. Now we put that. In fact, this was Dr. Arup's course in ASCRS, where I was speaking. In California, I think, is it? San Francisco, yeah. So, and you can see that fishnet-like iris that you have. But anyway, that's a small price to pay for getting away with this. And now I'm hydrating the wounds, and as I hydrate the wound, again I have iris prolapse. So it's not going to be very forgiving, but then, see, sometimes we try to go back and keep repositing the iris from the same port. It's a good idea to change your angle of attack and go through the side port and now manage that iris, and it kind of, very meekly gets back over there. So there are a host of predisposing conditions. As you can see, there are drugs, there are systemic conditions. So no amount of history taking can really prevent you from getting surprises. So you need to brace yourself and be prepared for it. So take-home messages with IFIS would be that you have a host of systemic, you need to take a good history, but then you will be surprises. It can occur with pre-op pupils 7 mm or smaller. It can occur more than 1 year after tamsulosin has been stopped, so that's no big deal. There's no point stopping it before surgery. It can occur within 3 to 7 days of tamsulosin treatment. And stopping tamsulosin is really of questionable value, because you're going to have urinary retention, and that could be a bigger problem. And women are often on tamsulosin because of urinary tract infections. That's quite common these days, actually. So surgical principles: long and tight incisions, gentle, slow hydrodissection, intracameral phenylephrine or adrenaline, and OVDs, and low IA parameters. These are the complications that we have. We've all been through that, and all of this could be avoided by using iris hooks or pupil expansion devices. So it's worth having a backup of iris hooks or pupil expansion devices. Now, like I said, mechanical dilatation of pupil is no good in IFIS, because it's going to come back again. It's an elastic pupil, it's a rubber band. You're going to stretch it, it's going to come back. So if it's a rigid pupil, you need to do what is called a controlled stretch, and then use a device which will serve a purpose. So I use iris hooks, pupil expansion rings, the Malyugin ring or the B-HEX or the I-ring, the other available. I've got 2 topics, so I've got 15 minutes, so I'm not really overstaying my welcome. So we will be talking of the B-HEX Pupil Expander. I've been fortunate to have my work recognized overseas and in India. We published our work first in the JCRS in 2014. It was the most read paper that year, and in IGO in December the last year, and again it's the most read paper. So there is no limit to the amount of thanks we can give or acknowledge the work of Professor Boris Malyugin. It's real groundbreaking work, bringing the Malyugin ring to us. Flexible square form from polypropylene suture, helical coils at the corners to engage the pupil margin. It's simply brilliant. Sorry. Can we go back? Can I go back, please? There's no option to go back. Okay, fine. Okay, so now we come to the B-HEX Pupil Expander. It's basically a single plane, thin device, notches and flanges design. It's 0.075 millimeters thick. That's 1/10 of a Malyugin ring or any other pupil expansion device. It's resiliently flexible, and now we recommend the 23 gauge forceps only for usage. The manipulator is out, and it's a very simple tool, and it's freely available now. Yeah, so injecting viscoelastic needs to be strategically done, a little bit viscoelastic under the pupil margin, and keep the anterior chamber shallow. That allows bowing of the iris, and it's very easy to tuck the flanges under the pupil margin, and that works for all pupil expansion devices. tuck the leading flange under the pupil margin, and then the alternate flanges go under the pupil margin. That's the second one, and that's the third one. It's a good idea to stabilize the eye as you are tucking those flanges. And once you inject viscoelastic, you have a regular hexagon which measures 5.5 millimeters from side to side. That's fairly good expansion for any kind of surgical work. What we have achieved is you can insert the device through a 1.5 millimeter incision and take it out through a 1 millimeter incision, which no device can do presently. So this is a 1.5 millimeter incision. We just position the notch flange junction to keep it leading so that the flanges do not get kicked, and that way we have the maximum advantage. And it's a bit of a tight fit over here, but then once you advance it and then you do a bit of flexing over there to get it back to its shape, and you support that trailing part over there with the forceps so it does not slip out, and then you tuck that trailing flange in, and then you tuck again. It's the same procedure. Alternate flanges go under the pupil margin, and you use your side port, main port, to access the flanges as they present to you. And once you have that, it's always a 5.5 millimeter. It may not look so because it depends upon the relative size with the effective, relation to the white to white. And that's a 1.5, and this is a 1 millimeter incision side port. And we're going to, so you can, stretch it. You can reposition it. You can move it like a picture frame. You can do whatever you want. These notches are pretty securely fixed over there. And when you want to remove it, you just hold that notch flange junction, disengage one notch over there, the other notch, and then just that third notch, and you can just draw it out of that 1 millimeter side port, and it walks out of that incision. That is something no pupil explantation device has been able to achieve till date. It's been used in flax by many surgeons, and this is courtesy Dr. Kasu-Prasad-Reddy, who was one of the first users, first investigators with the B-HEX pupil explantation device. Been a great support. So coming to the differences between the Malyugin ring and the B-HEX, there's no doubt that the Malyugin ring is great, but the biggest hurdle was it's a two-plane device, so it gets snagged in the incision, and it gets snagged in the inserter or the insertion. So what we did was we use a radically different concept and made the device single plane. That way we were basically, the pupil margin now straddles across the device. It's like a paper clip. The paper clip remains in the same plane. It's the paper which bends. So the iris can be bent reversibly, harmlessly. So that's what we're taking advantage of, and the device remains in the same plane, so it does not snag the incision on its way in and out. This is a case of intraocular miosis, where we use the B-HEX. This is where the B-HEX has a huge role to play, because you can see the notches at all times, and they're staring at you while you engage the pupil margin. I repeatedly use intracameral adrenaline, and despite that, the pupil has come down, and at this point it was a hard cataract. I did not want to take any chances, so we inject a little bit of viscoelastic over the anterior capsular rim, between the iris and the anterior capsular rim, create that little space, and then we take that B-HEX and with the forceps and tuck those flanges as we had. Now only when we tuck, now we are very careful, and we take that flange a little extra distance to be absolutely sure that we've not engaged the capsular rhexis margin. So you push it there, and you can see that capsular rhexis margin, otherwise it would get stuck over there, and that's instant verification. No device allows you that luxury of seeing where you're going. And that's 5.5 millimeters. You can move around that device and position it as you want. So now again you're back to your comfort zone where you can see the entire capsular rhexis margin and complete that surgery. And again, removal of a device has never been so easy. Just disengage the two notches on either side, and the device just can be dragged out, and you have a wonderful round pupil which looks beautiful on the next day. You can see that IFIS pupil over there. Now, what you need to differentiate is the rigid pupil from the elastic pupil. Inject a little bit of BSS or ring lactate through the side port. If the pupil expands, you know that it's an elastic pupil. You can use a pupil expansion device straight away. If the pupil does not expand when you inflate the anterior chamber, it's a rigid pupil and it's not going to work. So to differentiate, there is a fibrous ring over there which you need to break. So rigid pupils are better stretched to 4 to 5 millimeters before placing the iris hooks. Limited bimanual stretching works wonders. You could use a bulky pupil expander, but that would be a bit unwieldy. And that is the trade-off between the two devices. Thank you very much for your kind attention.